Hello and welcome. Let's talk about diuretics. So, what does it mean by diuretics? Agents which promote excretion of the solutes with isosmotic excretion of water are known as diuretics. Now, clinical uses. For edema due to cardiac, renal, and hepatic disease like CCA, pulmonary edema, cirrhosis of the liver, nephrotic syndrome, chronic renal failure, acute renal failure, diabetic nephropathy, and renal disease with SLE. Hypertension, heart failure, hypercalcemia, nephrolithiasis, glaucoma, mountain sickness, nephrogenic diabetes insipidus, and to decrease the intracranial pressure in trauma and inflammation, and SIDH. Now, classification of diuretics. Classification according to efficacy. Those with low efficacy. These includes osmotic diuretics with electrolytes like sodium and potassium salt, or non-electrolytes like mannitol, isosorbide, sucrose, and glycerol. ADH antagonists like demiclocycline, lithium salt. Carbonic anhydrase inhibitors like acetazolamide, dorzolamide, and methazolamide. Acidifying salts like ammonium chloride, arginine, hydrochloride. Now, xanthine derivatives like aminophylline, theophylline, caffeine. Potassium sparing diuretics like steroidal including spironolactone and eplerenone, and non-steroidal like triamterene and amiloride. Now, diuretics with moderate efficacy. These includes benzothiazide compounds like chlorothiazide, polythiazide, and others, and compounds related to benzothiazide like indapamide, zipamide, and clopamide. Now, the diuretics with high efficacy are high-serum diuretics, which includes loop diuretics like furosemide, bumetanide, torsemide. Now, classification according to the site of action. Those acting on proximal convoluted tubule like osmotic diuretics, carbonic anhydrase inhibitors, xanthine derivatives, and acidifying salts. On ascending limb of loop of Henle, loop diuretics. On DCT, benzothiazide compounds and other compounds related to thiazide. And DCT and collecting tubules. These includes potassium sparing diuretics like spironolactone. This is a picture showing the area of different type of diuretics. This is another picture showing the action, site of the action of different types of diuretics. Now, let's talk about osmotic diuretics. These are the small molecular weight substances that are filtered by the glomerulus but are not reabsorbed by the renal tubule and thus increase the osmolarity of the renal tubule. So it promotes water and electrolyte diuresis. These include drugs like mannitol and isosorbide. Now, mechanism of action. Mannitol inhibits water reabsorption in the proximal convoluted tubule, thin ascending limb of loop of Henle, and collecting ducts. The osmotic diuretics impose countervailing osmotic force and thereby increases the osmotic pressure of the tubular fluid and decreases the reabsorption of the water and increase urinary volume. It decreases the contact time between fluid and tubular epithelium, so there is decreased sodium reabsorption. There is increased extracellular volume by increasing the water loss from intracellular compartment, so there is a decrease in the renal release and there is decreased viscosity and increased renal blood flow. It may involve in the release of the prostaglandin. Now, clinical uses of osmotic diuresis: to maintain urinary volume, to prevent anuria in hemolysis, rhabdomyolysis, to facilitate elimination of the toxic drugs, to decrease intracranial pressure, and to decrease intraocular pressure. Now, adverse effects: expansion of extracellular fluid, hyponatremia, nausea, headache, vomiting, chills, hypovolemia, chest pain, and dehydration. Now, let's talk about carbonic anhydrase inhibitors. These are the unsubstituted sulfonamide derivatives and self-limited. These are nowadays not used diuretics, and the prototype is the acetazolamide. The carbonic anhydrase enzymes are present in many nephron sites but predominantly in luminal membrane of the proximal convoluted tubule where it catalyzes H2CO3. Now this is the reaction. Now pharmacokinetics. It is well absorbed orally and the diuresis starts within 30 minutes. It is maximum at 2 hours and persists for 12 hours. Now mechanism of action. It mainly inhibits bicarbonate reabsorption. Carbonic anhydrase inhibitors inhibit carbonic anhydrase on both the luminal membrane and in the PCT cell. So it decreases the carbon dioxide formation in the lumen, and there is decreased H2CO3 formation, and there is also decreased intracellular bicarbonate and hydrogen protein level. It decreases sodium reabsorption from the lumen due to the decreased H plus, which is needed for the sodium hydrogen antiporter. Filtered by filter HCO3 and sodium continue down the tubule, so there is increased accretion of the HCO3, which is major, and sodium and H plus is retained in body. As a result, it causes metabolic acidosis and urinary alkalosis. This is a picture showing mechanism of action of carbonic anhydrase inhibitors. Now, clinical use. Glaucoma, which is the major and the most common use because it decreases aqueous humor production and decreases the intraocular pressure. The drug used is dorzolamide. It is also used in acute mountain sickness, where it decreases cerebral edema by decreasing pH and formation of CSF. Metabolic alkalosis and urinary alkalization to acidic drug. Now, adverse effects. Hyperchloremic metabolic acidosis, bicarbonaturia, hyperchloremia, paresthesia, renal stone, hypersensitivity, and renal potassium wasting. Now, contraindication includes hepatic cirrhosis because the alkalization of the urine causes decrease in the urinary trapping and excretion of the ammonia, and it thereby increases the reabsorption of ammonia and leads to hepatic encephalopathy. Now, let's talk about thiazide diuretics. This is a moderately efficacious diuretics, and the mechanism of action includes thiazide blocks the electrically neutral sodium chloride cotransporter in the nitroconvoluted tubule. It inhibits sodium chloride reabsorption from the luminal side of epithelial cells in the nitroconvoluted tubule. This is a picture showing the mechanism of action of thiazide diuretics. Now, effects. Diuretic effects includes increased excretion of the sodium potassium chloride, so there is decrease in the plasma volume. Hypotensive effects includes decreased plasma volume, diminished responsiveness of the vascular smooth muscles to norepinephrine leading to vasodilatation, and decrease in peripheral vascular resistance. Release of the prostacyclin PGI2 from vascular smooth muscle. Now, effects. Hypokalemia, alkalosis, hypercalcemia. The delivery of the increased downstream sodium load enhances the loss of the potassium and hydrogen at the level of the collecting tubule. The calcium diffuses across the luminal membrane through the channels regulated by the parathyroid hormone and returned to the blood by sodium calcium antiporter, and inhibition of the sodium chloride cotransporter by thiazide causes decrease in the sodium inside the cell, which activates sodium calcium exchanger and leads to increase in the reabsorption of the calcium and thus causes hypercalcemia. Now, pharmacokinetics. It is orally active, it is not metabolized, and all secreted by acid secretory system in the PCT and compared to the secretion of uric acid. Indapamide is excreted primarily by bile. Now, clinical uses. For hypertension, CCF, edematous states due to chronic and renal and hepatic failure, nephrolithiasis due to idiopathic hypercalciuria, and nephrogenic diabetics insipidus, which is ADS resistance. Now, adverse effects. Hypokalemia, hyponatremia, hypotension, hypokalemic metabolic alkalosis, impaired carbohydrate tolerance, hyperlipidemia, and hyperuricemia. Allergic reaction may occur and other toxicities like weakness, fatigability, and paresthesia. Now, contraindication. Hepatic cirrhosis, patient taking digitalis, hypercalcemia, borderline renal failure, diabetes mellitus, and gouty arthritis. Advantages of thiazide diuretics. In hypertension, it is a drug of the choice for mild to moderate case. There is no interference in the acid-base balance, and it can be used in hypercalcemia. Now, advantages of the thiazide also includes the paradoxical use, which means it is usually used with cyclooxygenase inhibitor, which is indomethacin. It decreases the effective circulatory fluid volume, which may increase the oncotic pressure of the plasma protein and decreases the hydrostatic pressure of the peritubular capillaries of the PCT. There is increased sodium and water reabsorption from the proximal collecting tubule, and there is a decreased flow delivery to the collecting ducts, and there is decreased polyuria. Why indomethacin is given with thiazide? There is decrease in the glomerular filtration rate, increase in the fluid reabsorption from the PCT and DCT, and it potentiates the effects of the ADS on the principal cells of the collecting tubule. Now, let's talk about loop diuretics. These are the high serum diuretics and 15 to 25% of the glomerular filtration rate appears in the urine. It is highly efficacious and its effect increases with the increase in the dose. It is needed to, there is no need to combine with the others to potentiate the action, and it is an emergency diuretics as it causes maximum diuresis. It also can act in severe renal failure where there is only GFR 10 or lesser than 10 milliliter per minute. The drugs used are furosemide, ethacrynic acid, bumetanide, and torsemide. Now, mechanism of action. It inhibits sodium potassium 2 chloride co-transport present in the luminal membrane of the thick ascending limb of loop of Henle. There is decreased reabsorption of the sodium, potassium, and chloride, and it increases the excretion of the sodium and potassium. This is a picture showing the mechanism of action of loop diuretics. There is a decreased intercellular potassium. There is decreased back diffusion of the potassium, and there is decreased positive potential. There is decreased reabsorption of the calcium and magnesium, and there is increased excretion of the calcium and magnesium. There is increased sodium downstream, which leads to loss of sodium, loss of potassium and hydrogen, leading to alkalosis. It induces synthesis of the prostaglandin and increases renal blood flow, leading to increased glomerular filtration rate. It also has direct effects on the blood flow through several vascular bed. Now, pharmacokinetics. It is rapidly absorbed, out of which torsemide is more rapidly absorbed. The duration of action is furosemide 2 to 3 hours and torsemide is 4 hours. Half-life depends on the renal function, and the diuretic effects depends upon the secretion by the PCT. It is metabolized by liver and excreted by kidney. Now, clinical uses. For acute pulmonary edema, edema due to liver, lung, and heart disease like heart failure and acute renal failure, hypertension, acute hypercalcemia, hyperkalemia, anion overdose, hepatic cirrhosis and ascites, and nephrotic syndrome. Now, adverse effects. Hypokalemic metabolic alkalosis, hyponatremia, hypokalemia, hypochloremia, hypovolemia, hypocalcemia, hypomagnesemia, hyperuricemia, ototoxicity, allergy, and may decrease lithium clearance. Now, contraindications. Patients with sulfur sensitivity, pregnancy, gout, hypocalcemia. Now, drug interactions. NSAID with indomethacin, probenecid, sulfur drugs, aminoglycosides. Now, advantages of the furosemide over other diuretics. It is high efficacy drug, high ceiling, and maximum diuresis is 15 to 20% GFR. It can produce forceful diuresis. Combination with other drugs is not needed. It can act in severe renal failure. Glomerular filtration rate 10 milliliter per minute. Rapid onset of action. So, how does this drug act in congestive cardiac failure? By diuresis, by hypovolemia, and prostacyclin release. Now, let's talk about potassium sparing diuretics. It is less efficacious and its combination is needed. Only 5% glomerular filtrate appears in the urine, and there is no change in the renal blood flow. Now, drugs include steroidal like spironolactone, eplerenone, and non-steroidal like amiloride and triamterene. Now, mechanism of action. Spironolactone and eplerenone. It binds to the aldosterone receptor present in the principal cells of the collecting duct and blocks the effects of the principal and collecting cells. Amiloride and triamterene. It does not block the aldosterone receptor directly but interferes with the sodium entry through the epithelial sodium channels apical membrane of the collecting tubule. Now, mechanism of action. It causes decreased sodium reabsorption, decreased potassium excretion coupled to sodium reabsorption, and decreased hydrogen excretion. It thereby causes small increase in the sodium excretion, marked increase in the potassium and hydrogen excretion, resulting in the hyperkalemia and acidosis. This is a picture showing the mechanism of action of spironolactone or other potassium sparing drugs. Now, pharmacokinetics. The spironolactone and eplerenone are the synthetic steroid and competitive antagonist of the aldosterone. There is slow onset of the action, and there is greater selectivity for aldosterone receptor in case of eplerenone. Now, amiloride and triamterene. These are the direct inhibitors of the sodium flux in the CCT, and the amiloride has short half-life and more frequent use, and it is extensively metabolized and excreted by kidney with active metabolites. Triamterene is not metabolized. Now, clinical use. It is usually used in combination like edema with secondary hyperaldosteronism in congestive cardiac failure, hepatic cirrhosis, nephrotic syndrome, hypertension, and primary aldosteronism like Cone syndrome, ectopic ACTH production. Now, adverse effects: hyperkalemia, which is the most serious effect, gynecomastia by spironolactone, hyperchloremic metabolic acidosis and BPH by spironolactone, acute renal failure by triamterene and indomethacin, and kidney stone by triamterene. Now, contraindication: oral potassium and patient with the chronic renal insufficiency to avoid the risk of the hyperkalemia. Drug interactions: beta blockers hyperkalemia, AC inhibitors leading to hyperkalemia, and ketoconazole and itraconazole leading to markedly increase in the blood level of the epinephrine. End of the topic.